Welcome to this cardiac registry cast. Today we're discussing nomenclature and terminology and some basic concepts in congenital heart disease. The basic purpose of any system of nomenclature or terminology is to convey information to others. As diagnosticians, we need to convey diagnostic information to other clinicians caring for patients, to surgeons who might operate on patients, or to interventional cardiologists who might perform interventional procedures. In addition to conveying immediate information for clinical use, we are interested to collect data about prevalence of types of heart defects, about outcomes of treatment, so that we better know how to manage patients with congenital heart defects. In addition, we would like to better understand what causes heart defects and how they develop in the embryo. Only a unified system of nomenclature applied consistently can provide the raw data that we need to achieve these goals and objectives. The system of nomenclature that we would like should be descriptive. The name of a defect should provide a picture of the defect. Terms like type A1 are not very helpful, not very meaningful. It's much more useful to describe the defect, say, as tricuspid atresia with pulmonary atresia. The names used should have a one-to-one correspondence with the diagnostic entity. It's possible to have multiple names for a defect, like a membranous ventricular septal defect, or perimembranous ventricular septal defect, or paramembranous ventricular septal defect. These are all equivalent and can all be mapped to the same anatomical entity, so it's not really a problem. It would only be a problem if the same name referred to more than one anatomical entity. We also want the system to be quite inclusive so that all defects, even rare defects, have a place in the system of nomenclature. A large other category is not very helpful because it's very often these rare defects that can provide useful information about treatment or about causes and development of heart defects. Further, the system should be able to evolve as new defects are discovered. We need a consistent way to be able to add new entries into the system. The method for analyzing the heart that we use is called the segmental analysis. This is a stepwise method that first determines the cardiac position, where the heart is, either in the body or outside the body. Once that's determined, we think of the heart as basic segments and figure out the situs or organization or chirality of each of these segments. Then we're interested to know how the segments are aligned with each other, what segment drains into what. For example, normally the left ventricle drains to the aorta. The segments are also connected to each other by connecting segments. These connections are important and they're different from the alignments. For example, it's possible to have the aorta aligned with the left ventricle, as in the normal heart, by a connection of aortic to mitral fibrous continuity. It's also possible to have the same alignment, but to have conal muscle beneath the aorta separating it from the mitral valve. The implications of this are quite different. This latter case, with subaortic conus, is somewhat prone to developing muscular subaortic stenosis, for example. Once all of this basic information is obtained and cataloged, we would like to know about any associated defects, things like atrial or ventricular septal defects, or valvar stenosis, or persistent ductus, or these kinds of additional associated defects. And finally, we need to understand the physiology of the defect to be able to manage the patient both medically and surgically. We use a segmental analysis because the heart's a complex organ. It's very difficult to think of the heart in all its parts all at once. It's much more efficient to think of the heart as its basic building blocks or segments, to analyze each of these segment by segment, and then put together a comprehensive, complete diagnosis after all of the segments have been analyzed. The first step is to determine the position of the heart. Levocardia, where the heart's in the left chest, with the apex pointing to the left. Mesocardia, with the heart in the midline behind the sternum, with the apices pointing inferiorly. Or dextrocardia, where the heart's in the right chest, with the apex to the right. Rarely, ectopia cordis, with the heart partially or completely outside the chest. While the cardiac position can be determined from physical examination or a chest X-ray, we often find echocardiography convenient for this purpose. Subxiphoid views in approximately a coronal plane are useful to show the position of the heart. In this model, we can see the coronal plane of the body. The transducer is placed here in the upper abdomen, and the plane of sectioning of the heart extends superiorly and a little bit posteriorly. There is a left-right axis in this plane, so we can determine the left-right orientation of the heart. In the panel at the bottom on the right, we see levocardia with the apex pointing to the left. In the middle panel, the apices are pointing inferiorly and the heart is in the midline. In the lower panel on the left, the apex is pointing to the right with dextrocardia. Magnetic resonance imaging is also very useful for displaying the position of the heart. In the panel on the right, we see levocardia with the apex pointed to the left. In the middle panel, mesocardia with the two apices of the ventricles pointed inferiorly. And the panel on the left, the apex of the heart is pointed to the right, and there is dextrocardia. Rarely, the heart can be partially or completely outside the chest. This is a fetal echocardiogram in a fetus with partial ectopia cordis. In the image on the right, the wall of the body is seen here and here, with the heart extending out through the cleft in between. The left ventricle here and the right ventricle here. There is a ventricular septal defect in this patient with tetralogy of Fallot. This infant has complete ectopia cordis with the heart completely outside the chest. This is characterized by a high omphalocele and very high position of the umbilical cord. The heart is in front of the chest, extending up like so. This patient also had tetralogy of Fallot. Sometimes the heart is in the right chest, not because of true dextrocardia, but because of dextroposition or secondary dextrocardia. This is due to either hypoplasia of the right lung or to a space-occupying lesion in the left side of the chest, such as a diaphragmatic hernia. In this example, in the X-ray on the right, we see a very small right lung. The tracheobronchial tree is markedly abnormal with tracheal stenosis. The left lung is hyperexpanded and emphysematous and pushing the heart into the right chest. This is clear from the chest X-ray in the left panel. This is a case of secondary dextrocardia because of hypoplasia of the right lung. This 3D reconstruction from a magnetic resonance angiogram illustrates this point. The left lung is quite large and hyperexpanded here, while the right lung is hypoplastic and seen below the heart in the right chest. The heart has been moved into the right chest because of the small right lung. There is also sequestration of the right lower lobe, and we can see the sequestration artery here arising from the descending aorta. Despite its position in the right chest, the heart is oriented rather normally. Note the apices of the two ventricles, the white arrowhead indicating the apex of the right ventricle, and the yellow arrowhead the apex of the left ventricle. The apices are pointing leftward and inferiorly, as in a normal heart. The heart's just been shifted over into the right chest. Imaging planes that we would use to examine this heart are similar to those we would use for a normal heart, just shifted to the right chest instead of the left. Once we've determined where the heart is, then we can begin the segmental analysis. We think of the heart as three main segments: the atria, the ventricles, and the great arteries. The three main segments are connected by connecting segments: the atrioventricular canal between the atria and ventricles, and the conus or infundibulum between the ventricles and the great arteries. To describe the situs or organization of the three main segments, we use set nomenclature or set notation. This set has three elements, the first of which describes the atrial situs and atrial organization, the second, the ventricular loop or ventricular situs, and the third, the position of the great arteries. The atria can be either the usual atrium in situs solitus or inverted atria, the mirror image of situs solitus. In situs solitus or usual situs, the left atrium is left-sided, the right atrium is right-sided. In situs inversus, it's just the opposite. The right atrium is left-sided and the left atrium is right-sided. It's mirror imagery. In anatomy, inversion means left-right reversal with no anterior-posterior or superior-inferior change. It's simple mirror imagery. In the cartoon, the real finger touching the mirror is the index finger of a right hand. The mirror image finger is the index finger of a left hand, indicating left-right shift in the mirror image. However, the dorsal surface of both the real and mirror image fingers is up and the volar surface down, so there's no superior-inferior change, and the tip of both index fingers is at the surface of the mirror, with the hand in the back, so there's no anterior-posterior change. This is simple mirror imagery, a left-right reversal with no other change. We can illustrate this point with the opened right atrium of a heart with solitus atria and another heart with inverted atria. We can use the fossa ovalis as a point of reference in both of these hearts. In the heart with situs solitus, note that the tricuspid valve is to the left of the fossa ovalis, as is the coronary sinus. In the inverted heart, the tricuspid valve is to the right of the fossa ovalis, as is the coronary sinus. In both hearts, the superior vena cava is superior and the inferior vena cava is inferior because there's no superior-inferior change. However, in the Situs heart, the superior vena cava courses superiorly and rightward, while in the inverted heart, the superior vena cava courses superiorly and leftward. The right atrial appendage, if we brought it in front as it would normally lie, is leftward and anterior to the superior vena cava in the Situs heart, but rightward and anterior of the superior vena cava in the inverted heart. So again, there's no anterior-posterior change, only a left-right shift. We see the same left-right inversion in the left atrium as well. The septum primum here on the septal surface is our reference point in the Situs heart, and here in the inverted left atrium. Note that in these images, we're looking from the back so that the patient's left is this side of the screen and right is this side of the screen. So in the Situs heart, the mitral valve and left ventricle are here to the left of the fossa ovalis or septum primum, while in the inverted heart, the left ventricle and mitral valve are to the right of the septum primum or fossa ovalis. Similarly, the atrial appendage, which is superior in both cases, points superiorly and leftward in the Situs atrium, but superiorly and rightward in the inverted atrium. In the Situs atrium, it's the right pulmonary veins which are adjacent to the interatrial septum, while in the inverted heart, it's the left pulmonary veins that are adjacent to the interatrial septum. There are characteristics of both atria which allow us to determine which is which. For the right atrium, the most reliable characteristic is that it receives the coronary sinus. The pectinate muscle architecture is also a very reliable indicator of the right atrium. Typically in a right atrium, the pectinate muscles extend out of the atrial appendage and around the vestibule of the tricuspid valve. Practically, we often use the inferior vena cava as a marker of situs and as a marker of the right atrium. Particularly with echocardiography, it's easy to trace the inferior vena cava up into the right atrium. And this is a reasonably reliable sign. Also, septum secundum is prominently displayed on the right atrial septal surface, and the right atrial appendage is much larger, broader, and has a wide connection with the right atrial body. In this opened right atrium, we see several of the characteristics of a morphologically right atrium. Here's the orifice of coronary sinus draining into the atrium, the fossa ovalis with superior limbic band or septum secundum here displayed above the fossa, the inferior vena cava entering the floor of the right atrium as well. In this waxed heart specimen in the left panel, the ostium of coronary sinus is here behind the Thebesian valve. The coronary sinus tracks in the left AV groove behind the left atrium. Also, inferior vena cava is seen entering the right atrium behind the Eustachian valve, all characteristic features of the right atrium. The echocardiogram in the right panel is an apical view angled posteriorly to show us the inferior or posterior surface of the heart. Here in the left AV groove, we can see the length of coronary sinus and then see it connect with and drain into the right atrium. The right atrial pectinate muscles are seen here coursing around the tricuspid valve inferiorly toward the coronary sinus. This is very characteristic of a right atrium. The large right atrial appendage is seen in the wax specimen here, with pectinate muscles coursing across it and with a very broad opening into the body of the right atrium. On echocardiography, we often use the inferior vena cava as a marker for atrial situs. Here in Situs solatus, we see the inferior vena cava to the right within the liver and the descending aorta to the left of the spine. In Situs inversus, it's just the opposite. The inferior vena cava is here to the left and the aorta here to the right of the spine. In the middle panels, the apical view, as we saw before, shows coronary sinus coursing in the left AV groove into the right atrium. The upper panel is a suprasternal notch view showing the left innominate vein joining the right innominate vein to form the right superior vena cava. This is characteristic of Situs solatus, but not diagnostic. In the left atrium, the pectinate muscles are confined to the atrial appendage without spilling onto the walls of the left atrium. Consequently, the left atrial walls are quite smooth without trabeculations. A prominent feature of the left atrium is septum primum is displayed prominently on the left septal surface like a small hammock with insertions onto either side of septum secundum. The left atrial appendage tends to be quite small and finger-like with a small orifice joining the body of the atrium. In this opened left atrium, we see the hammock of septum primum here displayed on the left septal surface with insertions here and here onto septum secundum. The walls of the atrium are quite smooth without trabeculations. The small orifice of the left atrial appendage is seen here. Note that pectinate muscles do not spill out of the appendage onto the wall of the atrium. In the panel on the right, in this waxed heart with the distended atrium, we can see the pectinate muscles crossing the atrial appendage, but without extending onto the walls of the atrium. On echocardiography, we can often see the pulmonary veins here draining into the back of the left atrium and the left atrial appendage just in front of the left pulmonary veins. In the sagittal plane, in the right lower panel, one sees the left atrium here posteriorly and the right atrium anteriorly. These subxiphoid echocardiograms illustrate imaging of atrial situs solatus and situs inversus. The two upper echocardiograms are in approximately a coronal plane view, like the model to the right, so that there is a right-left axis in these images. Note that the right atrium is anterior and rightward in situs solatus, and the left atrium is posterior and leftward. The opposite is the case in situs inversus. The right atrium is anterior and leftward, and the left atrium posterior and rightward. We can tell the situs in this view because it has left-right coordinates. The two echocardiograms below, however, are in sagittal plane, as illustrated in the model to the right. In this case, there is no left-right coordinate, only superior-inferior and anterior-posterior. The left atrium is posterior in both, and the right atrium anterior in both. It's impossible to determine the atrial situs from a sagittal plane view because there's no left-right axis in the view, so we can't tell what's left and right, and we can't see left-right inversion. This is an important imaging principle for examining particularly atrial situs or ventricular looping. In some hearts with heterotaxy syndrome, it can be impossible to reliably determine the atrial situs. Either there's a common atrium and it's not possible to determine which part of it might be right and left, or the characteristics of the atria are ambiguous and it simply isn't possible to determine a right and left atrium. In that situation, we consider the atrial situs ambiguous. In this echocardiogram and photograph of a specimen, we can see an example of such a heart. In the upper left panel, there's a large common atrium with a small strand of atrial tissue crossing the middle of it. There's virtually no atrial septum here. Pulmonary veins are seen entering either side of the atrium, and in the echocardiogram below, we can see right and left hepatic veins entering the floor of the atrium separately. In the anatomical specimen to the right, we see typical right atrial pectinate muscles extending all around the atrium on both sides, and again this small strand of atrial septum in between. So it's very difficult in situations like this to determine the atrial situs, and we diagnose this as situs ambiguous. These 4 magnetic resonance images in a black blood sequence, all in coronal plane, illustrate some of the findings in situs ambiguous both in the heart and in the other viscera. In the upper left panel, we see the airway, and the right bronchus is here with a early upper lobe branch. The left bronchus is here with also an early left upper branch. Both are characteristic of a morphologically right bronchus. This suggests that both lungs have 3 lobes and are symmetrical, as we often see in patients with heterotaxy syndrome. In the right upper panel, we again see the small strand of atrial septum residual in this large common atrium. In the left lower panel, the white arrow indicates a right-sided inferior vena cava, and the yellow arrow a left-sided superior vena cava. In the right lower panel, the white arrows outline a large liver that extends all the way from the right abdominal wall to the left, characteristic of a symmetrical liver with relatively equal right and left lobes, often seen in heterotaxy syndrome. Also note the white arrowhead indicates a left-sided gallbladder. So the first letter in our set notation for segmental situs can either be an S for atrial situs solitus, the usual arrangement of the atria, I for situs inversus, or the mirror image arrangement of the atria, or A for situs ambiguus, or indeterminate arrangement of the atria. The ventricles also have characteristics that allow us to determine which is the right ventricle and which is the left ventricle. The names right and left ventricle should be thought of exactly as a name rather than an indicator of a location in space. The right ventricle can also be on the left side. but it has the same morphological characteristics as on the right side. The typical features are a trapezoidal shape to the ventricle, coarse trabeculations inside the right ventricle. The right ventricle is usually divided into a body or inlet part that receives the attachments of the tricuspid valve, and an outlet or infundibulum or conus that supports the pulmonary valve. The tricuspid valve, the valve of the right ventricle, typically has numerous attachments onto the interventricular septum. There is very little space between the septal or medial leaflet of the tricuspid valve and the interventricular septum. And because there is a conus or infundibulum associated with the right ventricle, the tricuspid valve and pulmonary valve are separated and not in continuity. There's muscle in between the two. The panel on the left shows the anterior surface of the right ventricle, and we can see the trapezoidal shape outlined by the AV groove to the right, the acute margin inferiorly, the septum and anterior wall to the left, and the pulmonary valve superiorly. Opening the right ventricle shows numerous coarse muscle bundles or trabeculations within the body of the right ventricle. This specimen illustrates the two parts of the right ventricle. The panel on the left shows the body or inflow portion of the right ventricle. This is the part that receives the insertions of the tricuspid valve and extends up to the papillary muscle of the conus, or the medial papillary muscle. The panel on the right shows the infundibulum or outflow portion of the right ventricle. This extends from the papillary muscle of the conus up to the pulmonary valve. This part tends to be more smooth-walled with less trabeculation, whereas the body or inflow portion is coarsely trabeculated as seen in the left panel. The two parts of the ventricle are shown well in this wax specimen in the left-hand panel on this slide. This is an unusual cut. We're looking from the ventricular septum toward the anterior or free wall of the right ventricle. So we're looking across the body of the right ventricle from the septum, from behind. The apex of the right ventricle is here, and tricuspid inflow is here. The infundibulum or outlet is above the constriction between the parietal band or infundibular septum and the septal band. The sinus or body portion of the right ventricle is below this constriction and receives the attachments of the tricuspid valve. The panel on the right shows another characteristic feature of the right ventricle, and that is the numerous septal attachments of the medial or septal leaflet of the tricuspid valve. The left ventricular characteristics include an ellipsoidal shape, much finer trabeculations than seen in the right ventricle, an adjacent inflow and outflow tract, discrete free wall papillary muscles with no attachments of the mitral valve onto the interventricular septum, and an outflow tract between the medial or septal mitral leaflet and the interventricular septum. Because there is typically no conal muscle beneath the aortic valve, there is aortic to mitral fibrous continuity. In contrast to the right ventricle, the left ventricle is ellipsoidal in shape from the outside, as seen in the left panel here. The opened left ventricle is more bullet-shaped or truncated ellipsoid, with the truncated or flat portion at the aortic to mitral fibrous continuity. Other characteristic features of the left ventricle include the smooth basal septal surface seen here and fine apical trabeculations. There are free wall papillary muscles in the left ventricle with no insertions of the mitral valve onto the interventricular septum. The posteromedial muscle here adjacent to the interventricular septum, and the anterolateral muscle here on the free wall. The mitral valve typically has insertions into both papillary muscles. Some have likened the shape of the left ventricle to a cut strawberry, with the white interior of the strawberry representing the cavity of the left ventricle and the red outside the myocardium. The inflow tract into the left ventricle through the mitral valve is here, virtually parallel to the outflow tract to the aortic valve. This is quite different from the right ventricle, where the inflow and outflow are at nearly 90 degrees with each other. And there is an outflow tract here between the interventricular septum and the medial leaflet of the mitral valve. Fibrous continuity between the aortic and mitral valves is also characteristic of the left ventricle. The continuity is typically between the non-coronary leaflet and about half of the left coronary leaflet and the anterior leaflet of the mitral valve. The membranous interventricular septum is seen here, just below the commissure between the right and non-coronary leaflets of the aortic valve. The ventricles can exist as either Situs or D-loop ventricles, or inversus or L-loop ventricles. We use the hand rule as a convenient and reliable way of analyzing the ventricular handedness or chirality. In the cartoon at the lower left, the anterior wall of the right ventricle has been removed so that we can see the septal surface in yellow and the medial leaflet or septal leaflet of the tricuspid valve in gray. A right hand is required to describe the Situs or D-looped right ventricle, with the thumb into the tricuspid orifice, the fingers out the outflow tract, and the palm against the septum. It's not possible to do that with the left hand. This is a right-handed or Situs or D-looped right ventricle. In the right lower cartoon, we see the mirror image of this, or an inverted or L-looped right ventricle. This requires a left hand with thumb into the tricuspid valve, fingers out the outflow, and the palm against the septum. You can't describe this ventricle with a right hand. So we can see that the normal right ventricle is right-handed. The inverted right ventricle is left-handed. One can use the hand rule also on the left ventricle, as illustrated in the two upper cartoons. The upper cartoon on the left shows again a D-loop or Situs left ventricle. This can only be described by a left hand, with the thumb through the mitral valve, the palm against the septum, and the fingers out the aortic valve. So a normal Situs or D-looped left ventricle is left-handed. The upper right cartoon shows an inverted or L-looped left ventricle. This is described by a right hand, with the thumb out the mitral valve, and the fingers out the aorta, and the palm against the septum. So a normal or Situs or D-looped left ventricle is a left hand. An inverted or L-looped left ventricle is a right hand. So it's rather easy to remember. In the normal heart, the right ventricle is a right hand, left ventricle is a left hand. It's just the opposite in the inverted heart. These heart specimens illustrate the same principle. The heart at the bottom right is a solitous or D-looped right ventricle. The anterior free wall is seen here, and the interventricular septum here. The little hand cartoon against the right ventricular septal surface, thumb in the tricuspid valve and fingers toward the pulmonary artery, must be a right hand to describe this solitous or D-looped right ventricle. The ventricle on the upper left is an inverted right ventricle. Note also that the patient had dextrocardia. The apex of the ventricle was to the patient's right side. The free wall is here. The interventricular septum is here. And again, the hand cartoon in this case has to be a left hand with the thumb in the tricuspid valve, fingers toward the pulmonary artery, and palm against the septum, because this is an inverted or L-looped right ventricle. So you can see that these are simply mirror images of each other. The same can be applied to the left ventricle. The heart specimen on the bottom right is a solitous or D-looped left ventricle. The interventricular septal surface is here, and the free wall back here, with papillary muscles indicated by the white arrowhead. Again, this requires a left hand with thumb in the mitral valve, fingers out the aorta, and palm against the septum to describe it. The inverted or L-looped left ventricle, superior and to the left here, can only be described by a right hand. So again, this illustrates the chirality or handedness of ventricles, that we can have one of two types, either a D-loop or solitous ventricles, or inverted or L-looped ventricles, and that the hand rule is particularly useful in analyzing the type of ventricle present. These subxiphoid echocardiograms illustrate this scene echocardiographically. The two panels on the right are a D-loop right ventricle above and a D-loop left ventricle below. The two panels on the left are L-looped or inverted ventricles, a right ventricle above and left ventricle below. And you can see that they're simply mirror images of each other. So the middle letter in the segmental set notation can either be a D for D-looped or solitous ventricles, an L for L-looped or inverted ventricles. Rarely we encounter particularly double inlet right ventricles where it's impossible to determine the loop, because it's impossible to determine where the septum is in these single right ventricles. In that case, we would use an X because we can't determine what the ventricular loop is, so it's an unknown loop indicated by the X. The great arteries are identified by their morphology as well. The aorta typically forms the aortic arch and gives origin to at least some of the brachiocephalic arteries. The pulmonary artery has a rather short trunk which bifurcates into right and left branch pulmonary arteries. However, it's important to keep in mind that there are significant exceptions. For example, the aortic arch can be interrupted so that the ascending aorta simply gives rise to one or two great arteries, and the descending aorta is supplied by a ductus from the pulmonary trunk, in which case there really is no arch. Brachiocephalic arteries can arise from the pulmonary artery from a residual ductus arteriosus. Branch pulmonary arteries can also arise from the ascending aorta, as in hemitruncus, or origin of a branch pulmonary artery from the ascending aorta. So one has to be wary and careful when applying the morphological criteria to identify the great arteries. In normally related great arteries, the arteries can be in Situs position, where the aorta is posterior and to the right, and the pulmonary artery anterior and to the left. Conversely, in Situs inversus, the aorta is posterior and to the left, and the pulmonary artery anterior and to the right. In both cases, the great arteries are normally aligned with the ventricles. That is, the aorta is aligned with the left ventricle and is connected to the left ventricle by aortic to mitral fibrous continuity, and the pulmonary artery is aligned with the right ventricle and connected to the right ventricle by a subpulmonary infundibular or conus. These two heart specimens illustrate normally related great arteries. The specimen to the right shows Situs normally related great arteries. Here, the aorta is posterior and to the right and forms an aortic arch. Brachiocephalic arteries arise from the aortic arch. The pulmonary artery is anterior and leftward. The pulmonary trunk is short with a bifurcation into a left pulmonary artery and a right pulmonary artery. Both great arteries are normally aligned with the ventricles. The mirror image of this in Situs inversus has the aorta posterior and to the left, just the opposite of what we saw in Situs great arteries. It forms an arch and has brachiocephalics arising from the aortic arch, as we saw in Situs Situs, just the mirror image of Situs Situs. Similarly, the pulmonary artery is anterior and to the right, just the opposite of what we saw in Situs normally related great arteries. The short pulmonary trunk ends in the pulmonary bifurcation into a left branch pulmonary artery and a right branch. Note that in Situs inversus, the pulmonary bifurcation is to the right of the ascending aorta, whereas in Situs Situs, the pulmonary bifurcation is to the left of the ascending aorta. Also note that in Situs Situs, it is the right pulmonary artery which passes behind the ascending aorta, whereas in Situs inversus, it's the left pulmonary artery that passes behind the ascending aorta. These echocardiograms illustrate Situs and inversus normally related great arteries. The echocardiogram to the right shows the aorta to the right and the pulmonary artery with bifurcation to the left, typical of Situs normally related great arteries. In contrast, the echocardiogram on the left shows inversus normally related great arteries. The aorta in this case is posterior and to the left, whereas the pulmonary artery is anterior and to the right. The bifurcation is to the right of the ascending aorta. Arteries that are not normally related to each other and to the ventricles are called malposed great arteries, or malposition of the great arteries. This typically occurs in abnormalities such as transposition or double outlet or other ventriculo-arterial alignment abnormalities. Here, the position of the aorta is used to name the type of malposition present. For example, in the cartoon to the left, we see the aorta is anterior and rightward. The malposition is then known as D or dextro malposition because of the rightward position of the aorta. Conversely, the cartoon on the right shows the aorta anterior and leftward, hence the term L malposition or levo because of the leftward position of the aorta. One can also have the aorta directly anterior to the pulmonary artery, which is often called A malposition for anterior. These echocardiograms illustrate D and L malposition of the great arteries. The left panel shows the aorta anterior and to the right, and the pulmonary artery posterior and to the left with the pulmonary bifurcation. This is an example of D malposition because the aorta is to the right or dextroposed. The panel on the right shows L malposition of the great arteries. In this case, the aorta is anterior and leftward, and the pulmonary artery posterior and rightward. The bifurcation, again, is to the right side in this case. This is an example of L or levo malposition because of the leftward location of the aorta. So, the syntax for describing the great arteries in the set notation is S or I for normally related great arteries, S for Situs, I for inversus normally related great arteries. In order to be S or I in the third position, the great arteries must be normally related to each other, as we see in this pair of heart specimens with Situs great arteries in the right panel, inversus great arteries in the left panel. But they must also be normally related to the ventricles. That is, the aorta is aligned with the left ventricle, and there is aortic to mitral fibrous continuity as indicated by the white arrow in the right panel. Similarly, there should be infundibular or conal muscle below the pulmonary artery and joining the pulmonary artery to the body of the right ventricle as shown in the left panel. So in order to use S or I, Situs or inversus normally related great arteries, in the third position of our set notation, the great arteries must be normally related to each other, as we saw in the previous slide, and to the ventricles, as we see in this slide. D, L, or A malposed or malposition of the great arteries is then used for anything else with two arteries. Anything other than normally related great arteries with normal relation between the great arteries and normal relation with the ventricles is called D, L, A malposition of the great arteries. Then we can also have situations where there is a single arterial route. Typically this is an aorta or a truncus. Many people would consider tetralogy of Fallot with pulmonary atresia or truncus as a type of normally related great arteries, of course usually Situs normally related great arteries. Others would consider that there is only a single great artery, so it's impossible to determine the relationship of the aorta to anything else because there isn't anything else, and would either leave the third set member blank or place an X. So the possibilities for the third member of the set are Situs, normally related S, inversus normally related I, or a malposition D, L, or A, depending on the position of the aorta, or a blank or an X if there's only one arterial root, the aorta or a truncus, so that it's impossible to determine the relative position of great arteries. This list illustrates some common segmental sets. Probably most people listening to this cardiac registry cast have Situs normally related great arteries, with Situs atria, D-looped ventricles, and Situs normally related great arteries for a cardiotype of SDS. Subjects with situs inversus totalis, a rare condition in which there is complete mirror imagery of the heart and all the other viscera, have inversus atria, L-looped ventricles, and inversus normally related great arteries for a cardiotype of ILI, just the mirror image of the usual cardiotype SDS. The most common type of transposition of the great arteries has Situs atria, D-looped ventricles, and D malposed or transposed great arteries. The aorta is anterior and to the right and aligned with the right ventricle. The pulmonary artery is posterior and to the left and aligned with the left ventricle, hence transposition. The D in the third position indicates dextroposition or a rightward aorta. Congenitally physiologically corrected transposition usually has Situs atria, but L-looped ventricles and L malposed or transposed great arteries, where the aorta is anterior and leftward. Many patients with asplenia syndrome have ambiguous atria, but D-looped ventricles and D malposed great arteries, typically double outlet right ventricle or transposition, for a cardiotype of ADD. There are, of course, many other cardiotypes that can and do exist. Alignment is another very important concept in describing the heart. What we mean by alignment is what drains into what. In this cartoon, you could see that the right atrium drains into the right ventricle and the left atrium into the left ventricle. This is usual alignment or concordant alignment. This is what we would expect. There are a number of possible atrioventricular alignments. Concordant, as we saw in the previous slide. Discordant, where just the opposite of the previous slide, where the right atrium drains into or is aligned with the left ventricle. A straddling AV valve, double inlet ventricle, where both AV valves drain into the same ventricle, and AV valve atresia. These are examples of concordant atrioventricular alignments in the left panel in situs solitus and in the right panel in situs inversus. In both cases, the right atrium drains into the right ventricle and the left atrium into the left ventricle. On the left, the atria are solitus and they're D-looped ventricles, whereas on the right, the atria inversus and there are L-looped ventricles. These are waxed hearts that have undergone a CT examination and then a three-dimensional reconstruction from the CT data set. The leftward panel here shows the right atrium aligned with, draining into, the right ventricle. The right panel shows the left atrium aligned with the left ventricle. This is concordant, or the usual alignment of the atria and ventricles. This could also occur in situs inversus, not shown here. It would simply be the mirror image of what we see here. Discordant AV alignment is when the right atrium is aligned inappropriately with the left ventricle, hence discordant, and the left atrium inappropriately with the right ventricle. In situs solatus, this usually occurs with solatus atria but L-looped ventricles. In situs inversus, it usually occurs with inverted atria but D-looped ventricles. Here's an example of atrioventricular discordance in a patient with corrected transposition. The right atrium, seen here, is aligned with a right-sided left ventricle, an inverted or L-looped left ventricle. We can see markers of the right atrium, the inferior vena cava draining into it, the ostium of coronary sinus coming into the right atrium, and we see also markers of the morphologically left ventricle. The medial leaflet of the mitral valve has no attachments to the septum. The septum is smooth-walled at the base and has fine trabeculations toward the apex, and there are free-wall papillary muscles that receives the insertions of the atrioventricular valve. On the other side, we see the left atrium with smooth walls and a typical left atrial appendage aligned with a left-sided right ventricle. We know it's a right ventricle because of the septal attachments of its medial AV valve leaflet here, because of the coarse trabeculations in the ventricle. All of these are markers for a morphologically right ventricle. So in this case, we have solatus atria, but L-looped ventricles. So there is atrioventricular situs discordance as well as alignment discordance, and this is usually the case. Straddling AV valve occurs when one AV valve is aligned with two ventricles and the other with only one. For example, in the example on the left, we see the right atrium aligned principally with the right ventricle, but with a straddling portion aligned with the left ventricle, so that the right atrium drains into both right ventricle and left ventricle, whereas the left atrium drains only into the left ventricle. This can also occur with the mitral valve or left AV valve in the case on the right. This waxed heart specimen illustrates straddling mitral valve. This is a short axis cut near the apex of the two ventricles. Right ventricle here and left ventricle here. There's a large anterior ventricular septal defect or outlet ventricular septal defect here. In the left ventricle, we see the mural or lateral leaflet of the mitral valve spanning between the anterolateral and posteromedial papillary muscles. In addition, we see the medial or septal leaflet that extends across the interventricular septum and has attachments onto papillary muscles in the right ventricular outflow. The inferior part of the leaflet is seen here. It also inserts into both the posteromedial and anterolateral papillary muscles. The straddling portion is indicated here by the white arrow. In this case, the left atrium is aligned principally with the left ventricle, but also partly with the right ventricle. The right atrium is aligned only with the right ventricle. So this is a straddling AV alignment, where one atrium is aligned with both ventricles and the other with a single ventricle. In double inlet ventricle, both atrioventricular valves are aligned with one ventricular chamber. In the cartoon on the left, double inlet left ventricle is illustrated. Here both the right atrium and the left atrium are aligned with a left ventricular chamber. Often there is an outlet chamber associated with it. On the right panel, we see illustrated double inlet right ventricle, which is much more rare. Again, both atria are aligned with a single right ventricular chamber, which may or may not be associated with a small left ventricular chamber. This waxed heart cut to show both inlets into a left ventricular chamber. The right atrium is right-sided. We see the orifice of the inferior vena cava. This right atrium drains into this left ventricle. The left atrium here receives the pulmonary veins and also drains through a separate AV valve into this left ventricular chamber. So this is double inlet left ventricle. Double inlet right ventricle is illustrated here. A right AV valve and a left AV valve both enter this single right ventricular chamber. It has very coarse trabeculations on the walls, and it has a muscular junction here between the inflow portion that receives the AV valves and the outflow portion above that supports the pulmonary artery on one side and the aorta on the other. The outlet or infundibular septum is seen here in between the aorta and pulmonary artery. This is typical of a double inlet right ventricle. AV valve atresia occurs when there is no opening between the atrium and ventricle on the same side. For example, in the cartoon on the left, the right atrium is aligned with a right ventricle, but the left atrium is not aligned with any ventricle. This is typical mitral atresia and occurs in things like hypoplastic left heart syndrome. Here, the left atrium drains across the interatrial septum and into the right atrium. So the right atrium is normally aligned with the right ventricle, but the left atrium is not aligned with either ventricle. On the other side, we see an example of L-looped or inverted tricuspid atresia. Here, the right-sided right atrium drains through a right-sided mitral valve into the right-sided left ventricle. So there's Situs atria, but L-looped left ventricle. The left atrium drains across the interatrial septum into the right atrium. There's no left AV valve here. This is tricuspid atresia left-sided, so that the left atrium is not aligned with either ventricle directly. This is a whacked specimen of a heart with tricuspid atresia. The large left atrium is aligned with the left ventricle and connected by means of a mitral valve. The right atrium, however, is not aligned with any ventricle. It has a blindly ending floor, and flow from the right atrium is across the foraminal valley and into the left atrium. There's no direct connection or alignment of the right atrium with a ventricle. If one placed a pin from the floor of the right atrium through its junction with the ventricles, one would end up either in the left ventricle or the interventricular septum. The right atrium it has no relation at all with the small outflow chamber seen anteriorly and to the left in this patient. Consequently, there's only a normal alignment of the left atrium, and the right atrium is not aligned with the ventricle at all. This waxed heart shows mitral atresia. Again, the right atrium is right-sided and the right ventricle right-sided. So this is SD. Right atrium is aligned with the right ventricle, but the left atrium is not directly aligned with either ventricle. It doesn't drain into either ventricle because of mitral atresia. The mitral valve ends blindly here above this tiny single papillary muscle in the left ventricle. So flow from the left atrium is across the atrial septum and into the right atrium. In the great majority of hearts, the situs of the atria and ventricles predicts the atrioventricular alignment. For example, with soletus atria and D-loop ventricles, that is, concordance between the situs of the atria and the ventricles, there is almost always atrioventricular alignment concordance. Similarly, with inverted atria and L-loop ventricles, there is both situs concordance and alignment concordance. There is said to be harmony between situs and alignment. Discordant situs also predicts discordant AV alignment. For example, with soletus atria but L-looped ventricles, there is situs discordance. Normally we would expect to have D-looped ventricles with soletus atria. In the presence of L-looped ventricles, there is situs discordance, and this predicts alignment discordance as well. The right atrium aligned with the left ventricle and left atrium with the right ventricle, and that occurs in most such cases. True for inversus atria and D-looped ventricles. Again, there's situs discordance. Inverted atria, D-loop ventricles, we would normally expect L-loop ventricles with inverted atria, and this predicts AV alignment discordance, left atrium aligned with right ventricle and right atrium with left ventricle. However, there are very rare hearts in which the situs of the atria and ventricles does not correctly predict atrioventricular alignment. In this example, we see atria in situs soletus and D-looped ventricles. The segmental set is soletus atria S, D-loop ventricles D, and soletus normally related great arteries S. However, in this rare case, there is atrioventricular alignment discordance. In this heart, the right atrium is aligned anomalously with the left ventricle. Similarly, the left atrium is aligned with the right ventricle. This happens because the ventricles are twisted or rotated. This almost always occurs in hearts with supero-inferior ventricles and crisscross AV valves. It seems that the rotation of the ventricles is what allows this very rare anomaly to occur. Ventriculo-arterial alignment indicates the relationship between the ventricles and the great arteries, or which great artery receives blood directly from which ventricle. Just as with atrioventricular alignments, there are a number of possibilities. Concordant ventriculo-arterial alignments indicate that the aorta receives blood from the left ventricle and the pulmonary artery from the right ventricle. As we will see, there are a number of possible arrangements in which this occurs. Transposition or discordant ventriculo-arterial alignment indicates just the opposite. That is, that the right ventricle is aligned with the aorta or ejects into the aorta, and the left ventricle into the pulmonary artery. Double outlet ventricle indicates exactly what the name says. Both great arteries are aligned with one ventricle and neither great artery with the other. The most common arrangement, of course, is double outlet right ventricle, in which both the aorta and the pulmonary artery are aligned with the right ventricle. Double outlet left ventricle is much more rare, but certainly does occur. Single arterial trunk is an uncommon type of ventriculo-arterial alignment in which there is a single great artery arising from the heart. This can either be a truncus, as in typical truncus arteriosus, or the aorta in cases of pulmonary atresia. Most often, the single arterial trunk straddles the interventricular septum, as in tetralogy of Fallot with pulmonary atresia, or in typical truncus. In some cases, however, the single arterial trunk, either a truncus or an aorta, can arise solely above the right ventricle, usually with a complete subarterial conus. Usually, concordant ventriculo-arterial alignment is associated with normally related great arteries, as illustrated in the left panel here. This is Situs normally related great arteries in delooped ventricles. The left ventricle is aligned with the aorta, and the right ventricle with the pulmonary artery. These waxed heart specimens illustrate the concept. The left specimen shows the right ventricle here, identified by the tricuspid valve with septal insertions and other features of the right ventricle, is aligned with a bifurcating pulmonary trunk. There is conal muscle in this case, separating the tricuspid valve below from the pulmonary valve above. On the specimen to the right, we see the left ventricle aligned with the aorta, identified because it forms an arch and gives rise to brachiocephalic arteries. And there is, in this case, mitral to aortic fibrous continuity. So this is an example of normally related great arteries, or ventriculo-arterial concordance. Another form of ventriculo-arterial concordance is anatomically corrected malposition of the great arteries. In this case, the great arteries are aligned with the correct ventricle, the pulmonary artery here aligned with the right ventricle, and the aorta here aligned with the left ventricle. However, the connections are quite abnormal. The aorta has a well-developed subaortic conus, whereas the pulmonary artery typically has a deficient or no subpulmonary conus. So the great arteries are aligned with the correct ventricle, but connected abnormally. There's conus connecting the aorta with the left ventricle, deficient subpulmonary conus, and there is usually discordance between the ventricular arterial situs and alignment. Typically, if there are D-loop ventricles, the aorta is to the left, so that the great arteries are in L position, DL, discordant ventricular arterial situs, but concordant ventricular arterial alignment. These echocardiograms are from a patient with anatomically corrected malposition of the great arteries SDL, Situs atria, D-looped ventricles, but L malposed great arteries. In the panel on the left, which is a subxiphoid long axis or paracoronal plane view, the right ventricle is here, identified by the tricuspid valve with septal attachments. The left ventricle here. There's a large anterior or outlet ventricular septal defect here above the septal-most attachment of the tricuspid valve. The pulmonary valve and pulmonary artery arise above the right ventricle. There's a small amount of conus or infundibulum here separating the pulmonary valve from the tricuspid valve. The subpulmonary infundibulum or conus is somewhat deficient in this case. When we put the echocardiogram in motion, the scan will be from posterior to anterior. We can see the tricuspid valve in the right ventricle and the pulmonary artery. Scanning more anteriorly, the leftward aorta comes into view, anterior and to the left, and completely aligned with the left ventricle. We'll go through the scan one more time, and there we can see the anterior leftward aorta aligned with the left ventricle. In the right panel, we see a short axis projection with the aorta now coming into view as we scan to the left, sitting above the left ventricle and separated from the mitral valve by subaortic infundibular muscle. The aortic valve is here, mitral valve is here, and this is all subaortic infundibulum or conus that joins the aorta to the left ventricle and separates the aortic valve from the mitral valve. And the aorta came into view as we scanned in this projection to the left because the aorta is in L position, or to the left of the pulmonary artery. This is typical of anatomically corrected malposition, to have situs discordance between the ventricular loop, which is D in this case, and the great artery position, which is L. Another type of concordant ventricular arterial alignment is exemplified by isolated infundibular arterial inversion, illustrated in the right panel. In this case, there are D-looped ventricles, but inversus normally related great arteries. There's still a subpulmonary infundibulum and aortic to mitral fibrous continuity, but the position of the great arteries is typical for situs inversus rather than for situs solitus. So there is situs discordance, D-loop ventricles, but inversus normally related great arteries, but alignment concordance. The right ventricle is aligned with the pulmonary artery and the aorta with the left ventricle. So we have VA, or ventricular arterial segmental situs discordance, DI, but alignment concordance. So these patients can be pink and otherwise normal. These echocardiograms illustrate an example of isolated infundibular arterial inversion, SDI. There are Situs atria, D-looped ventricles, but inversus, normally related great arteries. In the panel on the left, we see the right atrium here right-sided, left atrium here left-sided. The right ventricle is here to the right, and the left ventricle here to the left. So this is Situs atria with D-looped ventricles. Playing the echocardiogram shows normal flow from left atrium to left ventricle and right atrium to right ventricle. Scanning inferiorly shows the inferior vena cava and coronary sinus. In the middle panel, we see the outflows. The aorta is aligned with the left ventricle, while the pulmonary artery is aligned with the right ventricle. However, the aorta is posterior and leftward, while the pulmonary artery is anterior and rightward. The aorta is aligned with, normally, the left ventricle, but also connected normally by aortic to mitral fibrous continuity. The pulmonary artery is aligned with the right ventricle and also connected by subpulmonary conus. It's simply that the great arteries are inverted, so there's discordance between the situs of the ventricles and the situs of the great arteries. The panel on the right is a peristernal short axis view. We see the aorta here to the left and the pulmonary trunk to the right. In this case, the pulmonary bifurcation is also seen here to the right. Another type of ventriculo-arterial alignment is transposition or discordant ventriculo-arterial alignment. Here, the aorta is aligned with the right ventricle and the pulmonary artery with the left ventricle. As the cartoons illustrate, this can occur with D-looped ventricles as shown in the left panel or L-looped ventricles as shown in the right panel. Most often in transposition, there is a well-developed subaortic infundibulum or conus, while the pulmonary artery is connected to the left ventricle by pulmonary to mitral fibrous continuity. The most frequent type of transposition is in situs solitus with D-looped ventricles and D-transposed great arteries, SDD, as illustrated by these cut sections of waxed heart specimens. The specimen in the left panel shows the right atrium aligned with the right ventricle, Situs atria, and a D-loop right ventricle. A right hand with the thumb in the tricuspid valve, fingers out the aortic valve, and palm against the interventricular septum best describes this ventricle. Here, the aorta is aligned with this morphologically right ventricle that's a D-looped right ventricle. There's a well-developed subaortic infundibulum or conal muscle here supporting the aortic valve and separating it from the tricuspid valve below. The right panel shows the left ventricle aligned with the pulmonary artery. We can tell this is a left ventricle because there's a smooth septal surface and free wall papillary muscles that receive the insertion of the medial leaflet of the mitral valve. The pulmonary artery here, indicated by its bifurcation into a right and left branch, is aligned with the left ventricle. In this case, the white arrow illustrates pulmonary to mitral fibrous continuity. Another less common type of transposition is in the setting of Situs atria, but L-looped ventricles and L-transposed great arteries, the aorta being anterior and to the left. This is an example of atrioventricular as well as ventriculo-arterial discordance, often called double discordance. In the panel on the left, we see the right atrium, right-sided, typical of Situs atria, but it's aligned with a morphologically left ventricle and connected by a mitral valve. We know this is a left ventricle because there's a smooth septal surface. The medial leaflet of the mitral valve is separated from the septum by the outflow tract to the pulmonary artery. The bifurcating pulmonary artery here is aligned with this left ventricle that's right-sided and L-looped. So we have Situs atria, but L-looped ventricles, and the pulmonary artery in this case is posterior and to the right. In the panel to the right, we see a morphologically right ventricle, indicated by the septal attachments of the tricuspid valve, aligned with the aorta. The aorta is connected to the right ventricle by a large infundibular or conal chamber here. So there's conal muscle separating the aortic valve above from the tricuspid valve below. This is an example of corrected transposition, or congenitally physiologically corrected transposition, because in this situation the physiology is relatively normal. Blue blood from the right atrium ends up in the pulmonary artery, and red blood coming into the right ventricle from the left atrium through the tricuspid valve ends up in the aorta. In the absence of other abnormalities, such as a ventricular septal defect or pulmonary stenosis, these patients can be completely normal appearing with no symptoms. Another type of ventriculo-arterial alignment is a double outlet ventricle. This can either be double outlet right ventricle in the leftward cartoon or double outlet left ventricle in the rightward cartoon. Here, the one ventricle that supports both great arteries is aligned with both of the great arteries, and the other ventricle is aligned with neither. The ventricle that is not aligned with a great artery generally pumps blood through a ventricular septal defect into the other ventricle and whatever great artery is closest to the ventricular septal defect. As illustrated in these cartoons, most often in double outlet right ventricle there is bilateral subarterial conus, but this is certainly not always the case. There can be quite a bit of variability in the conal anatomy in double outlet right ventricle. Similarly, in the rightward panel in double outlet left ventricle, most often there is deficient or no subarterial conus. However, this is not the only conal arrangement or anatomy that can be associated with double outlet left ventricle. These waxed heart specimens illustrate two types of double outlet right ventricle. The panel on the right shows double outlet right ventricle SDD, Situs atria, D-looped ventricles, and D malposed great arteries. Here we see the smaller left ventricle here and the large right ventricle here to the right. There's a inferior or posterior muscular ventricular septal defect behind the septal leaflet of the tricuspid valve and quite separated from either of the great arteries. The aorta is here anterior and to the right, and the pulmonary artery here posterior and to the left. There is no subpulmonary conus. The pulmonary valve is in continuity with the tricuspid valve. However, there is a well-developed subaortic muscular conus here separating it from the tricuspid valve. In the panel on the left, we see a little more unusual type of double outlet right ventricle, SDL, where there is situs discordance between the ventricular loop, a D loop, and the position of the great arteries, L malposed great arteries. Most often, in D loop, the aorta is to the right, or would be a D malposition of the great arteries, but occasionally there can be L malposition associated with D-looped ventricles. In this heart specimen, the right atrium is seen here, aligned with the right ventricle through the tricuspid valve. The right ventricle is then aligned with both the aorta and the pulmonary artery. There's a ventricular septal defect here in the Y of septal band, with the left ventricle indicated by the arrow through the ventricular septal defect. In this case, there is a well-developed subaortic infundibulum here underneath the aortic valve, and a deficient but present subpulmonary infundibulum beneath the pulmonary valve. Double outlet left ventricle, a rare anomaly, is illustrated by this echocardiogram. The panel on the left is a subxiphoid long axis or paracoronal plane view. In this image, the patient's left is here and right here. Playing the image shows the aorta overriding the interventricular septum through a large ventricular septal defect. The pulmonary outflow tract is seen here, also arising from the left ventricle. Stopping the motion, we can see better the pulmonary outflow tract here. In this case, the aorta is to the right of the pulmonary outflow. Hence, the last letter in the segmental situs set is D, or D malposition of the great arteries with the aorta to the right. There's Situs atria, right atrium on the right, left atrium on the left, D-looped ventricles, and D malposed great arteries, D double outlet left ventricle. This is very much like tetralogy of Fallot. The pulmonary outflow tract is quite narrow, but there's almost no infundibular septum. There is some infundibular free wall beneath the pulmonary valve, but not beneath the aorta. Here we see aortic to tricuspid continuity. Neither of the great arteries is aligned with the right ventricle. In the subxiphoid short axis view on the right, we again see the large overriding aortic root which is very low and in continuity with the tricuspid valve and the mitral valve. In addition, the pulmonary outflow tract is seen posterior and leftward of the aorta. Here, there's very little space between the pulmonary valve above and the mitral valve below. So in this case of double outlet left ventricle, the subarterial conus is absent under the aorta and deficient under the pulmonary artery. Finally, one can have a single arterial trunk arising from the heart. In some cases, this trunk straddles the interventricular septum and receives blood directly from both ventricles, as in tetralogy of Fallot. One can have tetralogy of Fallot with pulmonary atresia, for example, where there's no main pulmonary trunk, and the source of pulmonary blood flow is either a ductus, as shown in the diagram on the left, or multiple collateral arteries. The other possibility for an overriding single arterial trunk, of course, is truncus arteriosus, illustrated in the right cartoon. Here we see a main pulmonary artery segment arising from the ascending part of the truncus before it divides into the aorta and the pulmonary artery. In both of these cases, the aorta or the truncus overrides the interventricular septum, and there's usually fibrous continuity between either the aortic valve or the truncal valve and the mitral valve. Because of the similarity of the arrangement of the single arterial trunk in both of these cases to what we see in tetralogy of Fallot, the orientation or the status of the great arteries is usually considered normally related great arteries in both of these cases. Consequently, in both cases here, the last letter of the segmental set notation is S for Situs, normally related great arteries. One could also make the case that since there's really only one arterial trunk, it's impossible to say that this is normally related great arteries, because this single arterial trunk really receives blood directly from both ventricles. I think either of these options can be argued for successfully. At our institution, we have typically considered both tetralogy of Fallot with pulmonary atresia and truncus forms of normally related great arteries, and used S in the last position to describe these. This waxed heart specimen is an example of truncus arteriosus type 1, or truncus with a main pulmonary artery component. In this case, the large truncal root seen here is aligned with both ventricles. The left ventricle and the right ventricle can easily eject into the truncal root. The white arrow indicates truncal to mitral fibrous continuity, so there's no subtruncal conus in this example. These cartoons illustrate another type of single arterial trunk in which either the truncus, illustrated in the left panel, or the aorta in the right panel, is completely aligned with the right ventricle and connected by means of a subarterial conus, indicated by the gray cylinder in the cartoons. This is clearly not an example of normally related great arteries. Further, there's only a single arterial root present here, so assigning a D or an L doesn't make any sense because there's no other great artery with which to compare the position of the single arterial trunk. Consequently, we either leave the last element of the set blank or place an X to describe these unusual hearts in which there is a right ventricular single arterial trunk, usually with complete subarterial conus. This can occur either in cases of pulmonary atresia, as illustrated on the right side, or in rare cases of truncus arteriosus. The echocardiogram here illustrates a case of truncus arteriosus with interrupted aortic arch, or a type 4 truncus, with complete subtruncal conus. The large truncal root and ascending portion of the truncus and main pulmonary artery is seen here. The left pulmonary artery originates here, and the pulmonary artery continues as the ductus into the descending aorta because there is an interrupted aortic arch. The small ascending aorta arises here and will be seen better as we put this echocardiogram in motion. The right ventricle is here in the front, and the left ventricle, which is rather small, is seen here posteriorly. As we put this in motion, we can see the two ventricles and the two atrioventricular valves, a typical tricuspid valve here in front, and now we can see the truncal root completely aligned with the right ventricle. There's a well-developed subtruncal conus seen here and here, separating the truncal valve from the tricuspid valve or mitral valve. In a parasternal view, we see the large main pulmonary artery component here and the small ascending aorta, giving rise only to an innominate artery and the left carotid artery because of a type B interruption. The ductus is seen here into the descending aorta, as well as the origin of the left subclavian artery. As we've seen, alignment means how one segment drains into the next segment, or how blood flows from one segment to the next. Connections, on the other hand, indicate how the segments are physically joined to each other. The atria and the ventricles are joined or connected by the atrioventricular junction or atrioventricular canal and the atrioventricular valves. Consequently, the type of connections that are possible are determined by the atrioventricular canal anatomy. The connections of the atria and ventricles are rather closely connected to the alignments, but they're clearly not the same thing. There are a number of types of atrioventricular connections. There can be separate valves into separate ventricles, a common valve into two ventricles, separate valves into one ventricle, double inlet ventricle, or common valve into one ventricle, a common inlet ventricle. Or there can be absent AV connection or AV valve atresia. This waxed specimen illustrates normal AV alignment and connection. The right atrium is aligned with the right ventricle, left atrium with the left ventricle, and connected by two separate atrioventricular valves, the tricuspid on the right and the mitral on the left, into the two ventricles. In this heart, however, while there are two atria and two ventricles, and the right atrium is aligned with the right ventricle and the left atrium with the left ventricle, there is a common AV orifice that connects both atria with both ventricles. So this is a common valve into two ventricles. Double inlet ventricle is just what we've seen before, both atrioventricular valves into either a morphologically left ventricle, as shown here, or a right ventricle. So this is double inlet ventricle, or two AV valves into one ventricle. Hearts in which there is a single atrioventricular valve draining a single atrium into one ventricle are often called AV valve atresia. There really are morphologically two separate cases here. One, exemplified by tricuspid atresia, as shown in the panels here, is simply absence of the atrioventricular connection on one side. In the panel on the right, we can see that the right atrium ends blindly. There is sulcus tissue extending deep into the AV groove on the right, all the way to the right coronary artery. There's really no potential communication between this right atrium and a right-sided chamber, the outlet chamber shown here. The only potential communication is between the right atrium and the left ventricle shown here. So there's really no right AV junction here with a right-sided chamber. This is a little bit different from what we see in typical mitral atresia, shown in this example, where there's a large tricuspid valve and a tiny atretic mitral valve. Atresia simply means that there is no opening or no hole in the valve. There is a tiny valve apparatus here, but it simply doesn't open. So the connection here is AV valve atresia, because there is a potential for communication between the left atrium and the left ventricle. So this is a little bit different from absent AV connection, and probably this is important for understanding the embryogenesis of these hearts. The ventricles and great arteries are connected or joined by a conus or infundibulum, and so the ventricular arterial connections clearly depend on the anatomy of the conus. We can have a complete subsemilunar conus, as illustrated in the panel on the left here. In this case, the pulmonary valve or the semilunar valve is above, and the tricuspid valve is seen below, and these are separated by a band of muscle, infundibular or conal muscle, seen here. This is a complete ring of muscle below this pulmonary valve that includes free wall as well as septum. In the right panel, we see the other kind of ventricular arterial connection, in which there is not a complete ring of conal muscle below this aortic valve. There is aortic, in this case, to mitral direct fibrous continuity. There's no intervening muscle here between the aortic valve and the mitral valve. There is some residual subarterial conal muscle here, particularly here below the right coronary leaflet of this aortic valve. This is the muscular outlet septum or infundibular septum, and this is what is missing in, for example, doubly committed subarterial defects. So these are the two ways in which the ventricles can be connected to the great arteries, either with a complete subsemilunar conus or with semilunar to AV valve fibrous continuity, indicating absence of a complete ring of conal muscle. So we can have 4 types, since there are 2 great arteries and 2 possible types of VA connection. We can have a complete subpulmonary conus, which we see typically in the normal heart, a complete subaortic conus only, which is the most common arrangement in regular or common transposition of the great arteries, SDD. One can see bilaterally complete subsemilunar conus. We often think of this as the prototype or archetype of double outlet right ventricle. And there can be absent subsemilunar conus bilaterally, that is, direct semilunar to AV valve fibrous continuity of both semilunar valves. And this can be seen in a number of situations, including double outlet left ventricle and transposition of the great arteries. While there are statistical associations, ventriculo-arterial alignment and ventriculo-arterial connection are only loosely associated. In other words, any given ventriculo-arterial alignment can often be associated with multiple types of ventriculo-arterial connection. In fact, in transposition, all 4 types of ventriculo-arterial connection can be seen. We'll use the following series of echocardiograms to illustrate this concept. The first series that we have is from a patient with only subpulmonary conus but transposition. The panel on the left shows the bifurcating pulmonary artery aligned with the left ventricle, and the aorta here aligned with the right ventricle, transposition. Note also that the aorta is in fibrous continuity with the tricuspid valve. There's no subaortic conus in this patient. The aortic valve here is in fibrous continuity with the tricuspid valve. The panel on the left shows a short axis view in the same patient. Again, the aorta is seen here, aligned with the right ventricle and in fibrous continuity with the tricuspid valve. On the other hand, the pulmonary artery, seen here, aligned with the left ventricle, but separated from the mitral valve by a large subpulmonary infundibulum. This infundibular muscle is often called the muscle of Muller, particularly when present in transposition of the great arteries. So this is discordant or transposition ventriculo-arterial alignment associated with only subpulmonary infundibulum as a connection. This is a much more typical type of transposition of the great arteries, in which there's only subaortic conus or infundibulum and pulmonary to mitral fibrous continuity. This is a subxiphoid short axis view where we see the right ventricle here and the aorta here. The aortic valve is separated from the tricuspid valve by infundibular muscle. The pulmonary valve is here in alignment with the left ventricle and connected by pulmonary to mitral fibrous continuity. As we watch the echocardiogram, we can see the tricuspid valve and the aortic valve, as well as the infundibular muscle separating the two. On the left side, we see the pulmonary valve and the mitral valve with pulmonary to mitral fibrous continuity. So in this case of transposition of the great arteries and ventricular septal defect, there is only subaortic conus with pulmonary to mitral fibrous continuity. Here we see an example of transposition with bilateral subarterial conus. The left panel is a subxiphoid long axis view. The right ventricle is aligned with the aorta, and the aortic valve is separated from the tricuspid valve by infundibular muscle. In the left panel, which is a short-axis subxiphoid view, we again see the pulmonary valve here aligned with the left ventricle and separated from the mitral valve by infundibular muscle. So this is, again, transposition of the great arteries, because the aorta is aligned with the right ventricle and the pulmonary artery with the left, but with bilateral subarterial conus as the type of connection. Finally, an example of transposition with bilaterally absent subarterial conus. The panel on the left is a subxiphoid short-axis view. In this case, we see the aorta here aligned with the right ventricle, and the pulmonary artery here aligned with the left ventricle. The pulmonary valve is in fibrous continuity with the mitral valve. Seen here. And on the other side of the heart, we see the tricuspid valve here in fibrous continuity with the aortic valve. In the peristernal short-axis view on the right, we see both semilunar valves at approximately the same anterior-posterior level, which is typical of absent subpulmonary and subaortic infundibulum. So in summary, when analyzing the heart, we're interested to determine the segmental situs, that is, how the various building blocks or segments of the heart are organized, their chirality, their position. We're also interested to understand how they're aligned with each other, what drains into what, and their connections, how they're physically joined one to the other. These are all different concepts, but they're all very important concepts. Atrioventricular situs, that is the situs of the atria and ventricles, is usually quite predictive of atrioventricular alignment. As we saw before, there are some extremely rare exceptions, but for the most part, once one determines the atrial and ventricular situs, one can predict the AV alignment. If there is atrioventricular alignment discordance, this is associated with cyanosis and is a cause of cyanosis. The treatment for this is an atrial switch operation. So here, the segmental analysis has indicated the cause of cyanosis as well as the treatment. We also know that atrioventricular connection is closely related to atrioventricular alignment. There are only a few, maybe even one type of atrioventricular connection that can be associated with any atrioventricular alignment. On the other hand, the situs of the ventricles and great arteries is much less predictive of ventriculo-arterial alignment. Again, ventriculo-arterial alignment discordance results in cyanosis. This is another cause of cyanosis, a typical example being transposition of the great arteries. Here the treatment, however, is an arterial switch operation because it's the great arteries that are switched. So again, our segmental analysis has led us to the cause of cyanosis as well as the treatment. We also know that ventriculo-arterial connection is much more loosely related to alignment than atrioventricular connection to atrioventricular alignment. There are multiple ventriculo-arterial connections that can be associated with any given ventriculo-arterial alignment. The connection is often of interest more because it predicts other abnormalities such as outflow tract obstruction. So we're interested to use this stepwise analytical approach to understand the heart. It's useful in any heart, but it's much more important and much more imperative that we use this kind of systematic approach in patients with complex heart disease. First, determine where the heart is. Once we know where the heart is, then it becomes possible to understand how we can adequately image the heart to make a correct diagnosis. Then we want to know the segmental situs, the chirality or organization of the main components of the heart, the main segments, and we express this using set notation. Then the segmental alignments and connections. Again, AV alignment is usually predicted by the situs of the atria and ventricles, and so we don't typically include this directly in the diagnostic summary. On the other hand, we know that ventriculo-arterial alignment is only loosely related to the situs of the ventricles and great arteries. Consequently, we usually state the ventriculo-arterial alignment as part of the main diagnosis. For example, transposition of the great arteries, SDV, or double outlet right ventricle, SLL, or whatever the case may be. But we state the ventriculo-arterial alignment as part of the diagnostic summary, since one can't reasonably infer this from the segmental information. And finally, we want to again examine the heart segment by segment, looking for other abnormalities, an atrial defect, a ventricular septal defect, pulmonary stenosis, or coarctation, or whatever happens to be in that particular segment of the heart. We do this in a segment by segment fashion so that we don't forget anything. And we typically write a report from a clinical imaging study or from an autopsy in the same way, so that, again, one doesn't forget key elements, but also so that the reader will know where to look in the diagnostic summary to find the information of interest. This organized, systematic method of reporting is very important, both to ensure completeness, but also to assist the reader in finding information. And physiology can be predicted from our segmental analysis, as we've seen in a few recent examples. And that, of course, is imperative to understand in order to help manage the patient.